tell Mithra if I can't see your face on the screen, or Jenna, I can see you. So even if you just like wave your hand around, I'm happy to stop and talk and answer questions along the way. They don't have to be saved for the end. Next slide. So of course, hypothyroidism can involve a billion things. I'm going to talk about just the basic fundamental things we get consults for all the time that are, you know, after a while, relatively straightforward. And then along the way, I'll kind of mention the things about pregnancy and elderly patients that pertain to each of the topics I'll cover. Next slide. So symptoms of hypothyroidism, very, very often people have no symptoms whatsoever. And we also know that people Google symptoms of hypothyroidism and read a number of things like fatigue and weight gain that can be due to a billion other things besides thyroid. And thankfully, when it is due to thyroid issues, we have labs to prove that it is or isn't. And it's a lot of finessing and trying to just figure out how to explain things to patients to convince them sometimes that it isn't in fact their thyroid and that the labs really don't lie and that these symptoms are very vague. I try to talk to patients a lot about how, you know, so I know that we've all faced this. So a patient will say, yeah, the labs look normal, but it's my thyroid and no one believes me. So I explain that that's part of why the normal range for a TSH is so broad, that it goes all the way from 0.35 up to 5.0, and different people can feel better or worse at different ends of the normal range. So if they are already on thyroid hormone, I will move them around in the normal range over, say, a year and see if they do in fact feel better or worse at certain ends of normal, and see if their symptoms change at all as we adjust the doses. For more than, of course, the placebo first 2 weeks I took this new dose, I felt great, and then I felt tired again. I think that over a year of adjusting people within the normal range, and then they still continue to have fatigue and weight gain, that sometimes is what's necessary to convince people that it isn't your thyroid, because we've done everything we can do within a safe, normal range, and you still have these symptoms. So, you know, a lot of it is talking to people, but it can cause anemia, and it even causes a rise in diastolic blood pressure, so a narrowing of the pulse pressure. That's something that we don't typically think of. And of course, in severe cases of hypothyroidism, they can present to the emergency room with official hypothermia, bradycardia. We don't expect to see any symptoms due to hypothyroidism if thyroid hormone levels are in the normal range. So, you know, if somebody presents hypothermic and they're on levothyroxine, so they have a diagnosis of hypothyroidism, but their levels are normal, their body does not know that it has a thyroid problem when the levels are in fact normal. So those symptoms and signs would have to be attributed to something else. Another thing that I didn't put in this talk that I'm suddenly remembering is that now that cold season is coming, sometimes I get questions from patients who have hypothyroidism and are on thyroid medicine, or even are hyperthyroid and are on methimazole or something like that. I wanted to pick up a cold medicine, but it says that if you have a thyroid problem, you have to be careful. So again, I explain to people that as long as your thyroid hormone levels are normal, whether it's from a medication or from your own thyroid working properly, your body doesn't know it has a thyroid problem. Therefore, you can take these cold medicines just like anybody else can. And then I explain that, you know, if a cold medicine says it's going to make you tired, well, if you have untreated hypothyroidism, you're going to be tired, and this cold medicine could make you more tired. Or at the other end of the spectrum, if you have overtreated hypothyroidism or untreated hyperthyroidism and your heart's racing and you feel hot and jittery and you take a non-drowsy cold pill, well, that will exacerbate those thyroid symptoms that those people are experiencing. So I reassure them that as long as their levels are normal, their body does not know it has a thyroid problem, and therefore those cold medicine preparations are fine. Next slide. So of course, the fundamental lab in anything thyroid starts with a TSH, and hypothyroidism involves looking at and finding a high TSH. Next slide. So it is in fact the best test to use, and it has been for decades and decades and continues to be the recommended blood test in every endocrine and American Thyroid Association guideline. It is very sensitive. It will, again, all these things I'm sort of saying today are things I say to the patients. And the TSH will move very dramatically for even very slight changes in the free T4 or free T3 levels. So if I were relying on T4 and T3 to tell me someone's inherent thyroid hormone levels, I won't be so aggressive in adjusting my levothyroxine dose because I'll only see tiny changes in those labs, whereas a TSH might move from 1 to 2 with just a little tiny thing. So therefore, a TSH is the most sensitive test, and all of our guidelines as far as what we should target for pregnancy and for after thyroid cancer treatment is all based on TSH results, not on T4 and T3 types of things. In someone who does not take any thyroid medication, TSH levels can actually fluctuate significantly even during any given day. There have been studies looking at euthyroid individuals, and every hour they check their TSH just to see what happens. And it will go up and down commonly throughout a 24-hour period, generally within the normal range, but depending on what time you happen to catch a patient's TSH who thinks they may have a thyroid problem or who's just getting screened for thyroid issues, their TSH may be in the middle or at the lower end or the higher end of normal. And if it feels like you might want to act on that TSH result, even though it's normal, make sure you do repeat it so that you can confirm that in fact it wasn't just, looking like it's at the slower end at that time that patient checked it, but in fact the next time it's at the speedy end, etc. And when I'm talking to providers or patients, I tend to use speedy end of normal and slow end of normal TSH because in my mind and for patients, it's more clear. If I say your thyroid levels are high, well, does that mean that they have too much thyroid hormone and therefore they are hyperthyroid? Or am I referring to their TSH and saying your TSH is high, in which case they have the opposite, which is hypothyroid? So when the TSH is at the lower end of normal, I call that the speedy end of normal. And if it's at the higher end of normal, I call it the slower end of normal. And then everyone who's listening knows what I'm talking about with me not having to specify the actual number and how it falls within the normal range. Our lab has normal TSH ranging from 0.35 up to 5.0. There's a lot of debate about what the upper end of normal TSH should be, with some labs saying that it should never be above 2.5, some saying 3.0. We have up to 5, and it's important to know that euthyroid people who are in their 70s and 80s actually have a TSH that averages out to around 7. And therefore, if a person shows up and is screened for hypothyroidism and their TSH is 7, then I generally do not start them on thyroid hormone simply because it might be a normal physiologic place for their body to be, and adding thyroid hormone to them may put undue pressure on their heart, their cardiovascular system in general. So that is a normal place for a TSH to be in people in their 70s and 80s. So I just remember 70 and 7. That helps me remember. Next slide, please. So other labs that can be drawn when we're checking people for thyroid issues include a free T4. This is generally more useful than a total T4. In pregnancy, we often use total levels, but for the majority of the population, free T4 is the better test. Now, we have good assays for free T4. They're not affected by estrogen changes or binding globulin changes. So a free T4 is a good test to check if you are trying to dig in and find other things that I'll talk about in a second. I would encourage everyone not to use a lab order that says TSH with a reflex T4. So I tell our fellows all the time, don't let a computer algorithm decide what blood tests you want. You decide if you want or need a free T4 level. Otherwise, a TSH is fundamentally the single best test to use. Next slide. T3 is a little bit stickier. Whether to order a free T3 versus a total T3, even in big hospital system labs, the assays that are used are sometimes unreliable. But when you're looking at total T3s, the same things that affect total T4s also affect total T3s. So it's really a toss-up from what you get used to looking at, whether you choose a free T3 to order or a total T3, if you feel that ordering any kind of T3 is warranted. And again, I'll talk about T4 and T3 in a moment, when to order them. Next slide. Okay, so the official diagnosis of hypothyroidism is when the TSH is high, but we really want to confirm it, and we check then a free T4. And if it's low, that is formally, officially hypothyroidism. And we all already know that. Next slide. But what if your TSH is high, but then you check the free T4 and it's normal? So we have a TSH suggesting hypothyroidism, but when we directly measure that free T4, which is the actual thyroid hormone floating around doing thyroid work, it's completely normal. Next slide. This is called subclinical hypothyroidism. And this subclinical term is referring not to presence or absence of symptoms. It's referring to this particular lab situation of a TSH that's high and a free T4 that is normal. So there are guidelines about this too. If the TSH is less than 10, when the T4 is normal, you do not have to start that person on levothyroxine. You would just check it again in a few months. It is more likely to normalize than not. Therefore, starting somebody after a single TSH check that's less than 10 but a little high isn't usually necessary. Now, what if you want to start them on levothyroxine, or the patient's very insistent, or they really are having symptoms that you believe are from thyroid, or you have repeated the TSH and it is like 3 months later and it's still above normal but less than 10. It's okay to go ahead and start them on a small dose of levothyroxine and move their TSH down into the normal range. If a person has thyroid peroxidase antibodies, which I'll describe more in detail in a couple slides, this means that they have Hashimoto's thyroiditis, just by definition, and their thyroid is a little more likely to progress to overt hypothyroidism with a high TSH and a low T4 at some point in the future. So if you're kind of on the fence and the patient's kind of wanting thyroid medicine, this is a situation where it wouldn't be crazy to start, again, a baby dose of levothyroxine. You check their TSH in 6 weeks, see if it moved their TSH at all towards normal. If not, you'd increase the dose, etc. But again, even in the presence of TPO antibodies, if they have this subclinical hypothyroidism, you do not have to start them on levothyroxine. It's just a decision after a discussion with the patient and your own personal preferences in practice. If the patient has a TSH that is elevated and they are pregnant or actively planning pregnancy, there are some different recommendations. So if they are already on levothyroxine, you definitely want to increase the dose. and move their TSH down to a target TSH of less than 2.5. Normal, but less than 2.5 for pregnancy. Now, if they are not already on levothyroxine, it's just a screening. The guidelines are much more wishy-washy about whether you would actually start someone on levothyroxine in pregnancy just because their TSH is a little bit elevated. It is, again, more likely to normalize. If that pregnant person has a slightly high TSH, not on levothyroxine yet, but has TPO antibodies, I would definitely start them on levothyroxine though, and move their TSH down to a less than 2.5 target. So again, if they're not on levothyroxine and pregnant and their TSH isn't absolutely perfect, the guidelines are not clear on whether or not to definitely start them on levothyroxine to move them to that target. There's no data to say that there's any difference in outcomes for the offspring or for the pregnancy itself, as long as that TSH isn't above 10. Now, if the TSH is above 10, you start them on levothyroxine, regardless. Next slide. Okay, here's another situation completely. What if the TSH is normal, not high like hypothyroidism or subclinical hypothyroidism? What if you, in the first step, ordered both a TSH and a free T4? And the T4 is low. Again, the TSH is normal. What is doing this? And say you repeat it and it still looks like this. The TSH is 2, but the free T4, the actual hormone coming out of the thyroid gland, is low, and they're not on thyroid medicine. Next slide. This is due to a pituitary problem. This normal TSH we call inappropriately normal. That is a favorite term in endocrine. Everything in endocrine kind of works in a seesaw. So if the T4 is low, that pituitary should be sensing that and sending out a stronger thyroid stimulating hormone, TSH. So if the TSH has not in fact reacted appropriately and gone up, that means the pituitary is broken. It can't respond properly to this low T4 coming out of the thyroid gland. So instead of a nice seesaw effect, one's high, one's low, and then it shifts and averages out in the middle, if one is low and this doesn't react properly, this is broken. So that means that you have a pituitary or central problem, and that person needs a pituitary evaluation. Next slide. Okay, so a little more about TPO antibodies, the thyroperoxidase antibodies. As opposed to thyroglobulin antibodies, which are much less specific, I never order thyroglobulin antibodies. They're only useful in a completely unrelated situation when we're monitoring somebody after surgery for thyroid cancer. That's it. TPO antibodies are much more specific to a diagnosis of Hashimoto's thyroid disease. So if you have these antibodies circulating around in your system, they are just waiting to attack your thyroid gland and eventually eat away at it and make it underperform. The number of antibodies is relatively irrelevant. You could have 100 above normal and have very aggressive ones, and you become hypothyroid in 6 months. You could have 3,000 of these antibodies measured annually for years, and you never need levothyroxine. Your thyroid, they're just lazy antibodies, and they never attack the thyroid, and your TSH continues to look completely normal. So I check these once ever. I tell the person you have Hashimoto's or you do not. And then I just continue to use the TSH from there on out to say, yes, you need thyroid medicine now, or nope, you still don't need it. So you can have positive antibodies without any thyroid destruction or thyroid hormone dysfunction. And the annual rate of becoming hypothyroid when you have these TPO antibodies is only 1 to 2%. So most people with Hashimoto's do not, in fact, actually become hypothyroid over their lifetime. it is just a little more likely than for somebody who doesn't have those antibodies. And again, I don't check the antibodies a year later once I tell them they have Hashimoto's, because even if the number of antibodies has tripled, it still doesn't mean that they're more or less likely to go on to develop hypothyroidism over their life. The TSH will tell me. The only real thing that we seem to have a little bit of data about that relates to the number of antibodies is a potential increased risk of miscarriage. So that data is super sketchy, but if you have had prior early miscarriages and you have TPO antibodies, you may be more likely to have miscarriages if those antibody levels are very high. Maybe starting levothyroxine can help reduce the rate of miscarriage, but again, that data is always under debate. Every year there's a new study and then a counter argument about that kind of thing. My tendency is if somebody's had miscarriage and they have Hashimoto's, if they're not on levothyroxine already, is to start them on 25 micrograms of levothyroxine, because some data says that might help. As long as the TSH stays within the normal range, I am not hurting them. And if it could help and they don't mind taking a pill, of course, if they don't want it, I wouldn't start it, then I feel that there's potential benefit with essentially minimal risk of harm. Next slide. Okay, so here's something that we all have heard. A patient says their thyroid's the problem, they know it, they're tired, and they've gained weight. So they want all the thyroid labs checked, not just that TSH you keep checking. So, next slide. If I have a patient who says that, this is what I do, and this is personal preference. This is not based on anything at all. I do a TSH, a free T4, a free T3, and TPO antibodies. And then I explain to them that from these labs, I can tell them if they have an autoimmune thyroid problem or not. I can also tell them that their pituitary gland is working fine and sending the proper signal to the thyroid gland. And I can tell them that they were not born with an enzyme deficiency that is making them unable to convert T4 into T3. And I can tell them all of those things with these labs, and then I explain again to them, because I know all these things now as a good starting baseline, we can rely on your TSH to tell us all thyroid things in the future. And when I explain all that in some detail, people believe me and feel that I've done everything and that I've heard them, and then they believe me when I say we can just use the TSH thereafter. Next slide. Okay, so how do we treat hypothyroidism? Levothyroxine is the best medication. It's essentially thyroid hormone in a pill. And it's, got some fillers in it. So sometimes people are sensitive to pink number 3 or yellow number 20. And there are a lot of different things I do to kind of address those concerns. So 50 micrograms are white. So if somebody thinks that they're allergic to a color, I'll put them on some combination of 50 microgram pills to get to the dose that they need, and then they often feel better. There's also a brand called Tyrosint, which has, I believe it's 3 ingredients. It's got the thyroid hormone and it's a gel cap. So it's the most simple set of ingredients, and people who have gluten allergies and think that, there might be gluten in their pills, they can use this Tyrosint medicine and often do very well. So how do we dose levothyroxine? Next slide, please. If they're not on any thyroid medicine and their TSH is just a little bit high, I'll usually start them on 50 micrograms a day, and I repeat the TSH in about 6 weeks, and then I adjust the dose more until I get their TSH either into the normal range and see how they feel, or closer to the speedy end of normal. For most young, healthy people, moving their TSH down to the 1 end of normal or even a little below that, as long as it's not below the normal range, is often where people feel best as far as what thyroid hormone can do. If they're still having thyroid symptoms when I've moved their TSH down to that end, like tiredness, etc., then I explain to them that they really need to dig into other potential reasons for their symptoms. Now, if their TSH at the starting point is somewhat higher, then I'll start them, these are just guesstimates, 75 to 100 micrograms a day. Again, I'll repeat the TSH in 6 weeks, adjust the dose up or down as I need to, and I always tell them if they start feeling kind of overly caffeinated, they can check their TSH sooner. At 6 weeks, you see the fullest effect of the change in dose. So if halfway through they're already symptomatic and I check then, it's too soon to see the full effect. But if already they're too far, one way or the other, I'll know early to change the dose. I usually move in about 25 microgram dose adjustments whenever I'm changing the dose. So I'm very unlikely to bypass either end of the normal range. But I do explain to patients to let me know if they feel jittery or can't sleep or tremor in their hands that's new, etc. Now, if their TSH is really high when I first see them, at like over 20 or something like that, that's when I'll use a weight-based dose, that 1.6 or 1.7 micrograms per kilo per day. And then again, I'll repeat their TSH in 4 to 6 weeks and adjust the dose as needed. If they've had a total thyroidectomy, then they're going to need weight-based dosing. And if their TSH is really high, you can presume that their own innate thyroid gland is making 0. But to start out someone whose TSH is only 6 or 7 on a weight-based dose of levothyroxine is usually providing them with too much thyroid hormone, because if their TSH is only 6 or 7, their own body is still providing a significant amount of thyroid hormone. It's still somewhat functional. It doesn't go from full on to fully dead. It just gradually slows down. So the dose that you want to use is really just to be considered a supplement to whatever their own thyroid is still able to make. So the weight-based dose is really if their TSH is super high and you know their thyroid's making 0, or they had a thyroidectomy and you know there is no thyroid to make anything. Now, if the patient is elderly, especially if they have a heart condition, it's recommended, somewhat regardless of what their TSH is, to start them at 25 micrograms a day and then move the dose up monthly or so that you don't put undue stress on their cardiovascular system. Next slide. Okay, and here's what I said earlier about a normal TSH on average in people who are 70 and up is often around 7. So you don't necessarily have to start anybody who's got a TSH in that range on levothyroxine. If they are pregnant and already on thyroid medicine, you can tell them that they are probably going to need a higher dose during pregnancy. Most women do, and it's usually about 25 to 30% more than what their prior to pregnancy thyroid hormone needs were. So to assimilate that, you can tell them, just take 2 extra pills of your current dose per week when you find out you're pregnant. And then a month later, you check their TSH. Because of the super long half-life of levothyroxine, whether it's the pill or our endogenous thyroid hormone, it's a week. The half-life is 7 days, which is why we can play with doses over the week, and it doesn't give them extra on Tuesday and extra on Friday. It averages out to a little bit extra all the days of the week. So if you tell them to take 2 extra pills 2 days a week, that will be roughly 25 to 30% more of their dose, and that will get them to where they need to be. But of course, everybody's different. Not every person needs the extra thyroid hormone during pregnancy. So you want to monitor their TSH. I check it almost monthly during pregnancy until they're almost, in the last 10 weeks of pregnancy and things don't change so much. So, like I've said a couple times, if they are on thyroid hormone and they're still having symptoms that when they looked it up could be ascribed to hypothyroidism, and I've moved their thyroid levels kind of around in that normal range and especially down into the speedier end of normal, then I do try to, convince them that it really can't be from thyroid now. We've tried thyroid levels of all sorts and you're still having symptoms, and so you need to kind of investigate other things. If someone has a pituitary problem that you know of, or they've had brain radiation for other reasons, or who knows what, and you can't trust the pituitary for whatever reason, you can't trust their pituitary, use, in these situations, the free T4 to guide dosing of levothyroxine, because that's going to be measuring the circulating amount of thyroid hormone in their body and not whether or not the pituitary, which is usually very sensitive, but in those cases, insensitive and unable to respond to the circulating thyroid hormone, use the free T4 to guide your dosing. You just want it in the normal range, and based on patient symptoms, you can tweak it, move it up and down within normal, but that's really the only time you use the free T4 to guide dosing. Next slide. As far as Armour thyroid or any porcine or pig-derived thyroid hormone, patients love it, and that's because it has a lot of T3 in it. Levothyroxine is pure T4. Our own thyroids make about whatever they're emitting every day is about 90% T4 with only about 10% T3. Most of the T3 that we measure in our blood tests was T4 that was converted into T3 in the periphery. Pigs make a bunch more T3 from their own thyroid gland than humans do. And these porcine thyroid concoctions are ground up pig thyroid gland put into capsules. So there is always more T3 in that capsule than what a human body would naturally be making. And also each capsule is not regulated compared to the next capsule. So this capsule may have 30% T3, the next capsule may have 18%, the next one may have 25%. So pill to pill, bottle to bottle, when it's a ground up gland from an animal, it's not a regulatable amount of either T4 or T3 in any capsule. So it can be very hard to get the labs to look right. Often you'll see a TSH that looks like they're hyperthyroid, but a T4 that looks like there's no T4 in their body, but a T3 that's super high. So you don't know, should you decrease the dose to fix the T3? Should you increase the dose to fix the T4? And then in 3 months, they didn't change anything, and now the labs look completely different. It's very difficult to regulate levels in most people who are on these types of thyroid replacement. So what I explain to people is, what I'd like to do is switch you to what's more physiologic for humans, which is to get the T4 in the form of levothyroxine. And then all of your cells, when they need it, will convert the T4 into T3. So if your heart needs extra energy, it's going to be converting T4 into T3 more. If you're force feeding T3 onto your body, your heart can't unconvert the T3 that's coming in that capsule. It's stuck with it. So you can't get rid of the extra T3 in the parts of your body that don't need it or want it right now. So it's not physiologic. So people feel more energized with T3 because it has a shorter half-life, so its onset of energizing action is faster. It's like today I feel more peppy. And I don't say this to people, but in my head I'm thinking, if you take amphetamines, you feel peppy too, but that doesn't mean that it's safe for you. So my next step in convincing people is to say, we'll start you on levothyroxine, we'll get that level therapeutic, and then I will check your T3 level. If it's low, I will add T3 in a separate pill, levothyroxine or cytomel, 5 micrograms a day. And then I can control which thing's too low, which thing's too high, and independently adjust the T4 and the T3 to keep all the levels normal. And patients are much more willing to switch off of the Armour when I explain to them that I'm willing to do this for them. And by and large, if I've moved their TSH down into the 0.8 or 0.9 or 1.0 range, they usually feel well, and I don't ever really need to add that T3 because almost nobody has one of those problems converting T4 into T3 in reality. Next slide. So I think this is the next to last slide. For patients for whom you've continued to increase the dose of levothyroxine, and their TSH is still 50, and they swear up and down that they're taking their pill, and they're on 400 micrograms a day of levothyroxine, which is beyond physiologic dosing for pretty much any BMI, then you start to wonder if they're in fact not taking their pill. And there's actually a way to test. So if, next slide, you do a very simple test. You tell the patient to not take their thyroid pill that morning and to bring their own bottle of levothyroxine into the office, and you check TSH and their T4 labs at baseline. And then, because remember, they're already supposedly taking 400 micrograms of levothyroxine a day and their TSH is still very high, you can safely give them 1,000 micrograms of levothyroxine, and you have to have them use their own pills, and they take them, but they have to be observed swallowing their 1,000 micrograms of levothyroxine. And then you measure the T4 levels at 1, 2, 3, 4, and 6 hours. And the TSH again at the 6-hour mark. And then you just see, did it absorb or not? Because even though there's a very long half-life for T4, there's actually a very quick blip up over a few hours after they've actually ingested that pill. And so if the percentage of uptake is greater than 60% from baseline, you know they can absorb it. You know that in fact they're just not taking their thyroid pill. And it helps you know if continuing to increase the dose is actually necessary to overcome some poor absorption issue versus a longer conversation of, you know, this is showing us that in fact you may be missing pills more often than you think, et cetera, et cetera. So this simple absorption test of labs, give them a big whopping dose and then measure the levels over the subsequent few hours, tells you if they're taking their pills or not. And we actually do it quite frequently and find that most people honestly just aren't taking their pills. I think that's the end of the slides, but can you click forward? Yeah. So any questions?
Thank you so much, Jessica. That was awesome. And there's so much that goes into the thyroid. That's incredible. Any questions for Jessica or comments about that didactic? Feel free to unmute or chat in. Janet?
Should we in family medicine be doing TPO antibody tests, do you think? It doesn't really affect the treatment of the hypothyroidism from my experience, but what do you think about us screening that? You know, I know you would do it in an endocrine consultation, but should we be doing it?
I think that if you know how to explain them, if they come back positive to the patient and reassure them that it really doesn't mean anything other than the fact that you need to check their TSH maybe annually to see if those antibodies affected their thyroid function, then it would be okay for, you know, a primary care physician to go ahead and check them. But otherwise, it doesn't really answer any questions. It only raises questions and makes people start looking up things and, you know, not understanding clearly that it's relatively insignificant. So I would say generally no.
Thank you, Janet. Hey, Dr. Polywall, how are you? Did you have any questions for Jessica?
Yeah, thank you for the nice presentation. I joined in between. What do you try to achieve, the TSH goal?
What
I mean,
are my TSH goals?
Yeah,
So, I guess I'll just sort of run through different population types. So if it's a young, healthy person who kind of feels tired, I will adjust their dose to keep their TSH at that speedier end of normal, like 0.8, 0.9, 1.0, around the 1 range. If it's somebody who feels too anxious or jittery or anything, even within the normal range, but at that speedier end, I will move them to I'll lighten up on the dose. Again, I generally move in 25 microgram increments. I'll move their TSH more to the middle of normal or even the slower end of normal. If it's someone who's pregnant and on levothyroxine, there are guidelines specifying that their TSH should be normal, but at the end less than 2.5. So the target TSH for pregnancy is a TSH less than 2.5, but still within normal range. So not suppressed below normal range. For people who are older or who have atrial fibrillation or things like that, I tend to keep their TSHs in the middle range, middle of normal TSH range, like around 2 or 3. And if they are elderly, like 70 or above, and they really have no symptoms, then keeping their TSH even a little above normal is okay, like up to 7 is actually okay, because like I was mentioning a little bit earlier, elderly people who are not on thyroid medication at all have often, on average, a TSH that just hovers around 7, and they are completely euthyroid. So it may be a physiologic adaptation of aging to put less metabolic demand on the body as a person gets older that leaves their TSH at that slightly slower end. So if the patient's not on levothyroxine and that's where their TSH is, I leave them alone. If they're really tired, etc., and they really want to start something, I'll put them on 25 micrograms and just move them into the beginning of normal, like at 4.7 or something like that, the slow end of normal, but not trying to push those patients towards that speedy end of the TSH normal range. I'll leave them at the slower end.
okay.
Did that answer your question?
Yeah, yes. It's just that for some people, I see so many fluctuations, especially when they're asymptomatic.
Yeah.
Okay, sometimes it's 0.5 and this, the next year I check it's 3.5, 4.5.
Yeah.
So
a lot of people, when you start them on thyroid medicine, again, you're usually starting at the lower doses because, again, it's just a supplement to what their thyroid's still making some of. And then whatever made the thyroid gland slow down in the first place is likely to continue over that person's life. So most people who get started on levothyroxine will need incremental increases in the dose of their thyroid medicine until that dose is maybe 100% of their physiologic needs. But it may take 20 years before that person's thyroid completely conks out. So some people, you start them on 25 micrograms, and if you're checking at 6 weeks to see if that dose is good and keeps their TSH where you want it, they may be on 25 micrograms for 3 years, and then suddenly their TSH looks good, but then suddenly in the next year their TSH is 7 on the same dose, you believe they're taking it, but that's because their thyroid for some reason conked out a bit more. So the dose needs to adjust to compensate for that. And then it may be that failure in thyroid function that started again is really aggressive and quick, and you may need to incrementally increase the dose pretty quickly for a little while, and then it slows down again. And there are even some people where whatever's bothering their thyroid kind of loosens up, and then a little bit of regeneration can happen in the thyroid if it's not too far gone, and the thyroid can contribute a little more of its own thyroid hormone, and you feel like gosh, now that same dose they've been on is suddenly too much. Now I'm decreasing the dose. So some of it is just the endogenous thyroid gland dying off at varying rates versus maybe regenerating a little bit every now and then. A lot of times thyroid hormone levels fluctuate because of changes in absorption in the stomach. So, you know, we tell people take it on an empty stomach and wait a good 30, 60 minutes before there are any pills, any food, anything like that are in the stomach, because thyroid pills love to bind up to other things. And if today 25% of your thyroid pill absorbs, tomorrow 100%, next week 62%, you're going to get fluctuations like that as well. And changes in weight can affect, because there's a different volume of distribution for the thyroid hormone to get to. So if you lost 50 pounds, you may need a lower dose, because you simply, and the blood test will tell you, the TSH is suddenly looking too low, you need to lighten up because there's just less body it has to get to. If somebody starts on any kind of antacid, by changing the acidity in the stomach, it also affects how the thyroid pill will be absorbed. So even if they take their Prilosec at bedtime and their thyroid pill 12 hours later, the acidity in the stomach is changed for that whole 24 hours. It's not the physical Prilosec pill that's bothering the Synthroid pill. It's the acidity in the stomach change that can affect the absorption of the thyroid medicine. So therefore, if somebody's starting on an antacid, I'll check their thyroid levels like 6 weeks later and see, did it change? Do I need to adjust the dose up or down? Or if they've been on Prilosec forever and now it's stopping, they will have more acidity in their stomach, and therefore the thyroid pill may absorb more efficiently now, and their dose may need to be decreased. So there are a lot of different factors that can come into play that have nothing to do with the patient actually taking their pill or not taking their pill. Something also that I remind patients is if they do forget a dose, take 2 the next day. That is another way we can play with that long half-life that thyroid hormone has, because if you miss, it's not like a blood pressure medicine where if you miss it today, your blood pressure will be sky high, and if you doubled up your blood pressure medicine, you'd be hypotensive all day. It's so slow moving that if you miss the pill today, you've still got weeks worth of thyroid hormone in your system. So take 2 tomorrow. If you're supposed to get 7 pills in a week, get your 7 pills in. It's okay if on one of the days you took 2 and one day you missed. Try to get all 7 in. And those things help keep the levels more stable.
Okay, thank you. And
Sure.
there is another question. I have a patient who is mentally challenged, and he moved from somewhere, some other part of the West Virginia, and he's on Armour thyroid, which I personally also don't like because of the same reason that it's hard to titrate the medication dose. But for some reason, his PCP said that it should not be changed to regular levothyroxine. Okay, can you think of any obvious reason, any big reason that somebody needs to be on Armour thyroid and cannot be changed to levothyroxine?
No. No, not at all.
Okay, thank you.
Mm-hmm.
Thank you all so much. Were there any other comments or questions you wanted to have addressed with Jessica? I know we had a few people hop on in the middle of your didactic, Jessica, and I think Donna actually had some connection issues, so she apologized for connection.
Okay. Thank you.
Thank you all so much. Thank you, Jessica, for that.
Thank you, it was excellent.
Sure, thank you.
I just have one quick announcement before we part ways. So our next session that was originally for November 25th is actually canceled for Thanksgiving. So the next time we'll all meet will be on December 9th, and Melissa Phillips is discussing avoiding holiday pitfalls. So keep an eye out for that reminder email. We'll see you guys next time. Thank you.
Thank you.